as we move forward into this Millennium War. Hospitals will continue to shrink, essentially becoming big intensive care units. Yes. If you're an elderly person and you're in the hospital for more than X number of days, and your DRG was one of a class, the federal government won't pay for you anymore because you should have been progressing care. All of these quality controls have been put into place, and more are coming. Now, if you're discharged and on Medicare, and you're readmitted within a certain number of days, the government will not pay for you. Why? Because that was a game that hospitals played, and doctors. They discharge you for one day and readmit you. And it was also that the reimbursement stream could start again. So the government fixed them. They said, if you come back within a certain number of days, you're not going to get anything for this admission. No reimbursement. All right, technology will have a dramatic impact. And there's going to, just like it has, laparoscopic surgery. Oh my heavens. Anyone that does an open surgery for a gallbladder today, I have to question where their head is. Laparoscopic surgery, almost anything can be done. Now, one of you may say, but what if the doctor suspects cancer? Then he goes in and he takes a biopsy, or she takes a biopsy, and sits there with their hands covered with a sterile towel and waits till the lab says it's yes cancer or no. That's what they do in the best medical centers today. They don't have you come in for another admission. They don't cut you open for simple things, and this is going to just increase in the future as we get even more sophisticated laparoscopic devices. These are tubes with little cameras on them or little knives on them, and they make a slit that you can cover with a Band-Aid later, and they go in, and if you have to have a gallbladder removed, they suck it out. That's all. And their little cameras allow them to totally investigate what's going on. This has changed the face of surgery in this country. And it also creates more ethical dilemmas associated with cost, quality, and access. Should the patient in East Overshoes, Wisconsin, have access to these things as well as the patient in New York City? Yes. It's an ethical dilemma. But what if the physician doesn't prepare to do these things? Then you get rid of the physician. Or you make a requirement that the physician go back to school periodically. The hospital, if it has the technology, should establish criteria that not all physicians can use all technology, and on and on. I don't have to tell you, but the ethical dilemmas are primary. All right, there's going to be universal access to a minimum standard of health care. There's going to be, especially for the poor, the near poor, the unemployed, and the underserved. And that's what ACA 2010 guarantees. The medical domination of the system will wane. And I told you last month, it's not only that we're seeing physicians leave medicine, we're seeing fewer people prepare for medicine. Now, that scares me. It says to me, am I going to have less bright people ministering to me? All right? And if I go into the healthcare system, I gotta be there. Believe me, I do not go in for frivolity. And if I go in, I want the very best. Are those people going to be there? It's no longer a guarantee to get rich. When you consider the malpractice, the fact that a lot of physicians are employees now, they do not work for themselves, they work for a hospital, and that hospital gives them a limited salary, but the medical domination of the field will wane. There are less students trying to get in. Probably only the very top medical school will be an attraction. And there are as many men as women do. The whole face of medicine has changed. And personal response, it's my hope that personal responsibility will grow, and I have seen it grow with over-the-counter testing. You can test your hemoglobin now. Buy a kit to do it. You're as smart as most laboratory techs. Why not? You can test your own urine. Find out if you're spilling sugar into it. Why would I pay someone to do it when I can buy a kit for $3 and do it myself? The pregnancy tests were the first step down this road, but there are more and more diagnostic kits that you can get, so you'll have a personal responsibility for diagnostics with the internet, please. Most of the patients you'll meet, I told you last week, consumerism. They'll know as much as you about what's wrong with them. And self-help groups are wonderful. If you've had a mastectomy, there is a Reach for Recovery group for women. Women who've had the problem or men who have had their problems, speaking to people who have just had this label. There's going to be an industry emphasis on primary care. You see that from ACA 2010. And consumers will have control over their healthcare choices. This has been the case for several years now. There is no physician that will tell you what you should have done. Except they don't have courses like him. They don't know how to speak to people. But if you've been diagnosed with cancer, you go in to see a physician. Let's hope that you know something about the disease. Here's where nurses could have a fertile employment situation. Advocating and educating the consumer to their medical conditions. You go in to see an oncologist today, and they'll tell you you have some options with your disease. Surgery, radiation, and or chemotherapy. What's your thoughts? Most people have no thoughts. They don't have experience with this. And that's scary. But doctors are very reticent to say, if it were me, I would select this. And I would be very reticent to take their advice. Environmental health is getting a big play, you know that. And community-based integrated services will continue. Alternate treatment, we mentioned that last week, is booming. I think in the next year or two, you're going to see the age for Medicare eligibility raised. It was talked about during the recent election. It's going to become reality, raising the age to what? 60. It's 65 now, maybe 70, and a means test is going to come, whether you like it or not. We're being dominated by the democratic philosophy. I don't want to get into a discussion of political science things here, but you're going to see a means test so that everyone will not be entitled to the same, the well-to-do will get less. And the public will demand guarantees of continued competency from providers. That's already happened. The number of suits initiated. Very few go to court, you know. But in ACA, in Obamacare, there's a demand for tort reform. We had better be careful about that, because there have been some horrible situations in medical practice, and I happen to think that you have the right to be compensated for that. Oh, I mean, well, some horrible ones. We didn't get to that section in the book, but we'll talk when we get there. But when you've been intensely harmed, you should be compensated. And most minor things are settled out of court. They're not clogging up the courts. Dominance of health care by the government is going to escalate, but there will be more public-private sector partnerships. Now, this is uniquely American. And about 10 years ago, Gro Brundtland, B-R-U-T-L-A-N-D, she was the president of the World Health Organization. She's a Danish physician who doesn't like Americans too much. I've met her. She's a wonderful lady, but she's suspicious of us and all this stuff, you know. Even though we liberated them during World War II, she's still suspicious of us. But she, before she retired, she wrote a position paper. I don't think, you could search the World Health Organization website and see if it's there. But she said, and it was particularly funny knowing her biases, she said that without a doubt the only way to get quality health care to people is public-private sector partnerships. And she went on from there. But in the U.S., public hospitals are not seen as the best. If you didn't know that, open your eyes. Quality and creativity in the U.S. comes out of private sector. Why? Because we're not hampered by government. We can gallop ahead and do what we need, and the government picks it up. All right? So there will be more, hopefully, public-private partnerships in delivering services, administering plans, every conceivable dimension of healthcare. Look, for an instance, at healthcare in New York City. The premier hospitals there are all private. You know that, don't you? There are some run by the Health and Hospital Corporation. The only one which is noteworthy is Bellevue, which opened 2 days ago, by the way. I was devastated by Sandy, and they just reopened. I hope this storm doesn't close them again. But Bellevue for trauma is exceptional. But all the other hospitals, health and hospitals, they serve the people. They're good in that perspective. But the ones that are making the breakthrough, are doing the simulation, are doing the cancer research, are all private. Sloan Kettering, Columbia, Weill Cornell, Mount Sinai, all private. All right? And because of that, they can move forward faster. Okay, why don't you take 10 minutes and don't look outside too much, because it's going to scare me. I'm not looking until I have to shovel my way to my car. We'll leave. Just take 5 or 10 minutes so that you're with me, and we'll try to leave a little early so that you can get home. Do any of you have classes this afternoon? No, one. Yeah, I would check. Let me check and see if there's been any reversal of that stay opening. So just take about 5 or 7 minutes just to get your blood flowing. Sure.
Tyler, are you going to stop it?
Yeah. Next week we're
Coffee.
no, we finished So by 11 you'll know. And classes for Saturday have been called off. There are Saturday classes. So any of you that have it, you won't. All right, ACA is the Patient Protection and Affordable Care Act of 2010. And this is the cornerstone of the Obama administration. Listen, when Medicare, and Kaye were made the law of the land, there were as many dark corners in it as in this. And over the years, different things have been clarified, perfected, so I'm hoping this goes the same route. We have too much invested in it to have it kicked out vis-a-vis the Supreme Court, but I'm sure there'll be attempts. Why? Because this represents in many areas a very big burden for the states. And in our culture, there's a thing known as states' rights. We went over that at the beginning of the semester. Each state is autonomous in health, education, and welfare. And that's why, for instance, nursing home reimbursement, and we went through talking about nursing homes and the options for home care and the cost, and you saw from your book or one of the slides that over 20% of the cost of nursing homes is paid under Medicaid, all right? That's the state program. And although the federal government gives half of the monies, where $1 of federal money, of state money goes into a program, the state has control. That's the way our country works. And I, too, over the years, have gone through periods where I said we should have universal this or universal that, a universal license for nurses, and all of these things which set us apart should be universal. But once you travel, you see the beauty of our country with its different complexion and different type of people and different mentalities from state to state. Very different. I used to laugh at Texas. That was a joke to me. But then you realize the only state that has kept out of the red. They're doing something right down there. And California now, where it used to be deep in the black, they used to harvest money out there, is dramatically in the red because of the number of undocumented aliens in California. That's what's breaking their back financially. So, with all of these things, what do we have in ACA, in the Patient Care, the Affordable Care Act? We have universal coverage. And I just talked to one of your classmates about that. He had some good ideas for a paper. And remember, there are sample papers on the course content with the PowerPoint, all right? But he was wondering, is it healthcare a right or a privilege? That's been done. But it's still, it's a good topic if you come up with new ideas. But more than that, I suggested, what is a basic standard of health care? We're promising to give health care to everybody, virtually, everybody that's legal. But what is the basic standard? In New Jersey, as soon as enough people were given the right to a certain therapeutic or diagnostic approach through their health care insurance, that right was handed over to those who are on Medicaid, the program for the poor. So there was a time when transplants of any type were not guaranteed for the poor. Some did get them because they were donated service, the same as in the old days, donated service by the hospital and donated a service by the physician, but it was not guaranteed. As transplants became more common, and this committee that makes these decisions is a state committee, but it's housed at Blue Cross and Blue Shield right here in Newark. The committee saw that transplants were becoming common. Kidneys were the first. So they said, no, once this becomes common, the poor have a right to it. So it went on Medicaid. And that's how Medicaid expanded. Now, I believe, Medicaid offers fertility services to the poor. All right? In other words, it's become common. The rich can get it, or middle class can get it if they have Blue Cross and Blue Shield. Therefore, you should have it. That's how it worked in New Jersey. I don't know if it worked that way in every other state. I'm sure it does in New York. New York is very similar, except New York is even more generous, much more generous, dollar-wise, with their poor. So, in talking about what is the standard, what about a heart transplant for an 80-year-old man? And that's what we were talking about up here. And your classmate said, well, 80-year-old, how many years do you have to give? But is it the quality or the quantity? A heart transplant for an 18-year-old or 20-year-old drug addict who's been in prison a few times versus a heart transplant for, I gave the example, there are many famous people in New Jersey, but the Gorenstein rings are the seminal work that forms the foundation for calculus worldwide. Gorenstein was in New Brunswick his whole life. The man who invented streptomycin, which after penicillin was one of the early antibiotics, it represents the cure for tuberculosis. It was the first cure. He was in New Brunswick, working in a lab for his whole life. He invented or he patented streptomycin. He didn't get rich because if you patent anything as a professor around here, the school gets the rights to it. But he made a dramatic contribution. I would say if Gorenstein or the inventor, and I can't remember his name, I should, of streptomycin needed a heart transplant, I'd be willing to guarantee with a year or two more of life, they would give more to the society probably than all of us combined. I'd be willing to give that. So what is a basic standard of care? That's something that's going to be really argued about. There are the little things that have been already settled, like mammograms and cancer screening. Well, you know, that's small dollars, and it's self-evident that it's going to be a good investment. But what really is the universal standard? Is there one? So ACA 2010 speaks about universal coverage for everyone within limits. What those limits are is going to be a drag-out fight, but I'm sure you can see now it's a significant decision. Insurance exchanges. There are going to be groups of insurance policies that award benefits at a different level, and therefore cost a different amount, set up in the state. Some states have already requested an exemption from this part of the law. They don't want to set up exchanges. They want to establish a policy which will define what the consumer will get. I don't know if that's a good topic. It's very tricky, so you have to be careful, but more and more is cropping up discussing this. Cost-sharing credits. In other words, you'll get coverage for free if you're at the poverty level. If you're above the poverty level, up to 400% of the poverty level, you'll get a good amount of help, but you won't get it all free. And the devil's in the detail here. And I wouldn't go worrying about it, but it's just that it's going to operate on a cost-sharing credit basis. It's interesting that currently, in 2009, and there's been no change the last time I went in and looked, which was a year ago, the poverty level for a family of 3 is $18,310 in the state of New Jersey. Now, how do you get around that? There are ways to get around that, too. Families in which the principal breadwinners are not married are construed as separate families, perhaps. I mean, you can't claim one kid for 2 families. But when you come down to it, and I know about Cory Booker's attempt to live on welfare, but how do you feel about $18,000? Could you live on $18,000? You couldn't. Come on, talk it up.
No.
No. Okay. You what?
Very low income.
It's a low income.
It's possible.
But everyone at that level or below, who's a family of 3, and a family of 2, a singleton, I think is 11,000, gets welfare aid. And that quickly adds up. I'll let you do the arithmetic if you're interested. Penalties for employers if their employees use tax credits. That means any employer that has any people up to 400% of the poverty level is penalized for the tax credits they use. Do you hear me? Any employer, except people with less than 25 employees, I think, whose employees use tax credits, and that would be up to 400% of the poverty level, because you get tax credits up to that level, will be penalized. All right? If I were an employer, that would disenchant me with hiring any full-time workers. Do you hear? That's how you get around it. Americans are very creative, by the way. They can find a way out of any box you put them in. And even if you didn't originally come from America, it seems once you hit the soil here, you become creative. And these are the things that make us creative. But you hear what I'm saying? Employers are responsible for the tax credits used by employees. I wouldn't be. Go ahead. You don't know what? Tax credits means that the government is going to assume some of the cost of your health care.
Is this also including the tax credits for children?
Oh, sure.
Because if you have a low income, you can qualify also for the tax credit.
Sure.
So it's like 5,000 or something like
Well, in your book, isn't there a table? I thought I put a table in there. How much you get with 1 dependent, 2 dependents, 5 dependents, it goes up, but it does not go up in proportion. There, I think, is a computation of basic living, rent, gas and electric, and after that floor for each person, there's an increase. Do you understand what I mean then? All right. So, in other words, if you make 398% of the poverty level, you'll be given some tax credits which will lower the cost of your insurance that you buy from the pool that the government is going to establish, or that in New Jersey Governor Christie's going to establish, because I think he said he's not going to comply. And frankly, I think we could do better ourselves too. But anyway, I don't think New Jersey is going to comply. But if you have workers that you have on your payroll, and a lot of workers that are making low salaries because they're doing low-level work, do you hear? You're going to have to pay tax credits for all these people so that they can get the policies from the state. That's what tax credit means. But what I'm saying is, if you're creative, there's a way to get out of this. Do not claim them as employees. Claim them as independent contractors, and there's a big difference. A lot of nurses work as independent contractors. Independent contractors pay no tax. The employer doesn't take any tax out of your wages. You have to pay it yourself. You're responsible.
It's also including the tax credits from like all of those employers, for those institutions who will do the abortion. This is the
okay, abortion is still a black hole. Do you know what I mean, a black hole?
But you know, the Obama insurance also included. So those who are against the abortion, we will have a choice to not pay because everything is going to be taken from the.
Let me give you an example. We have a lot of hospitals. No, we don't have a lot anymore. We have 87 hospitals. We had 120 something, not a few years ago. But those hospitals have a lot of low-paid workers, nurses, aides, for instance. Would they have to, well, yes, they'd be responsible, the employer, for the tax credits for those people. But what policies they'd be offered is what is being debated now. Do they allow for abortion, birth control? That's, you had your hand up back there.
Yeah. Is that penalty, is it created to ensure that the employers actually provide their employees with healthcare benefits or something?
They don't have to. ACA takes that away from the employees, from the employers. They don't have to provide benefits. What they do have to do, if the people are making a low salary, is they have to be responsible. They have to pay a penalty that is used for tax credits. You get what I mean? You're giving the whole responsibility over to the government. And that's what the Supreme Court decision was about. Remember, during the election, the Supreme Court decision finally came out and said this is not a penalty, it's just a cost of doing business. Okay, increase Medicaid to 133% of the federal poverty level. Increase Medicaid so that those people have more free cash to use for their health. I believe that would be the argument when it's increasing Medicaid. Medicaid is the program for the poor, and so they're upping it. No coverage for abortion, except with the help of the mother, or incest and rape are the issue. no abortions. State-based co-ops, that's the same as what we call the insurance exchange, with different plans. In other words, different plans will come together. And with your tax credits or with your own money, you'll be able to choose one of the plans, and hopefully you'll do it after being conversant about what the plans in Plan A offer compared to B and C. Each one will be different, and there will be a scale. They call it in the legislation bronze, gold, and silver, or something like that. In other words, each plan will give you more or less. All right. They're the same indicators as we talked about last week in managed care. One of the big ones is, can you go to a specialist provider without going through your primary? Right? You know what a primary is. The cheapest plans usually have a requirement that you have a primary provider, and you can't go to any specialist, no matter how obvious it is what you have, unless you go to that primary first. And behind the scenes, the primaries are graded on how many people go on to a specialist, because specialists are compensated higher. Children in ACA are dependent up to 26 if you can prove they're dependent. Now, we can't play games here. You know, if you have a son or daughter that's working someplace and living independently, you do not qualify. But, and frankly, how do you, I'm asking the wrong group. How do you feel about that? Being able to be covered on your guardian or your parents' health care policy until you're 26. How do you feel? Yeah.
I think that's a good idea because, you know, since there's emerging adulthood, you know, most people take longer to get a full-time career job-wise, and you need that in order to get health care.
All right, and why I'm smiling, I think you're probably right. I have to adjust my thinking to the new generation. There is a new generation. I was, by the time I was 22, I was married and had 3 children. And was going to school nights and worked a full-time job during the day. There was no time for growing up, literally. Today, many people need that luxury. But in order for me to support it, you have to prove to me that at the end of that period, you are substantially on your way and you're contributing something to society. If it's just covering you to 26 with tax credits and everything that's coming out of the government, because there is a lot behind the scenes here that hasn't even been talked about, if that's all it's going to be, I'm not going to support you until you're 26. Go there and see how you like that. That means without health insurance. A lot of young people do that. It's risky. But for people particularly who are trying to get established, yes, in a career, it's very justified. But we can't make those decisions one-on-one. All right, there's going to be no rejection because of pre-existing policies, pre-existing conditions. In New Jersey, we've had this for 40 years. But, they can't reject you for health insurance, but they can charge you an awful lot. That's the hook. I know people who have had several primary cancer sites, have been diagnosed with fourth stage cancer. go to work just to get the policy. They can't reject you. What they do, they charge the employer more money for your policy if you're getting it free, or if you no insurer can reject you but can charge you more because of pre-existing conditions. The ACA is silent on this. And what the federal government, remember, this is federal, it's not state. But what starts at the federal usually filters down to the state. But there are not many states that have an exemption because of pre-existing conditions. We're one of the few. All right, basic health needs, emphasizing preventive and wellness programs. That's all great. But when do we get to the stage where we're personally responsible for our own wellness? Now, there's been a lot said about obesity. There's been a lot said about smoking and a lot of talk about penalizing the obese and the smoker. That's what the massive cigarette cases were. Some years ago in this country, lawyers made fortunes, some of them, on representing the cigarette industry. And this was the case. We're allowing access to this stuff for people, so therefore shouldn't we be responsible? But they argue that we create the stress and we create the environment for this. So the society should be responsible. There is going to be a lot, and where does self-care come in? There's going to be a lot of argument over this. Administrative simplicity, it's been proven that processing bills through Medicare and Medicaid costs about 2 or 3%. It's done very easily. Why can't that be done for the whole nation? Because the nation, on a whole, invests about 25% of its healthcare dollar in administrative things. Why can't we process like we do for Medicare or Medicaid? Demonstrations for tort reform. We already talked about that. Expand home care services and discourage hospitalizations. I talked to you a little bit about that, about the never events. Never events are things that should never happen. You should never have to be readmitted in 2 days. If you were discharged, you should be well enough to go home. So there are penalties for all these things, and we'll discuss them later under legislation again. Increased payments for primary care services. A lot of primary care services are very underpaid. The routine physical, mammographies, paid very little. There's a push to increase payment. Discourage financial relationships within and among the healthcare community. How many doctors refer you for your x-rays, your mammography, into a system where if you explored carefully, they're a major owner? All right? Now, it may mean nothing, or it may mean a lot of dollars, but there is a part of ACA which discourages these relationships. And there's a big part of ACA that talks about accountable care organizations and medical homes and coordination of care. And this is good for nursing. These are the words that are used. They are new structural units. Medical home, accountable care organizations, ACOs, by those in the business. These are coordinating vehicles, which particularly for the person who suffers from a chronic illness and has high medical cost, coordinates their care. In other words, you're being discharged from a hospital. You don't go right away. Someone from ACO comes up, talks to you about whether your home is suited for a person with your problems, who's going to be there to look in on you at least once in a while, even goes home and does a home assessment for you before you're discharged. These are the accountable care organizations in the legislation can be headed by an advanced practice nurse. All right? The person who heads the team and is responsible for the organization is the most logical one based on the patients you serve. Common sense. Not the doctor, because he's or she's the doctor. All right, it's a different mentality. And medical home projects are much the same. It's a different name, but coordination of care is the hallmark of these types of models. And there are big incentives to maintain community living. I mentioned to you that in New Jersey, we have a bill that was passed 2 years ago that guarantees to the elderly money in their hand to meet their needs if they select to live home versus go into a nursing home, assisted living, one of those type of places. It has been underutilized. It has been researched. It has been researched through the benevolence of AARP, the American Association of Retired People, because they pushed this dramatically. And what we found, once you admit a disabled or elderly or frail person to a nursing home or assisted living, it's tough to get them to agree to go back to the community. So you have to stop them at the door, literally. You have to see them before they make the decision to go to a nursing home. It's like you become socialized into nursing home. We first tried to get the clients to go back out to community living. It didn't work. So right now, we're trying to make the point to these people when they're in the hospital, and in the old days, or just a few months ago, they were told, you can go to a nursing home, and these are the ones that have openings, and perhaps your daughter would like to go and look. Instead, we're saying, going home is an option, and nurses are in those roles of trying to maintain community placement. All right, we talked about the environmentally impaired. Modifications to Part D of Medicare. Part D of Medicare is the drug plan. All right? Part A is for the hospital. Part B is for any outpatient services, including advanced practice nurses, physicians, clinics, home care, etc. Part C is for Medicare managed care. It's called Medicare Advantage, and everything is covered. Many seniors use that because their drugs are covered under C. And D is the drug plan, which has a large donut hole. What is a donut hole? Anybody know what the donut hole is? Somebody? Yeah. D only covers those who have a great deal of medication expense, a very high bill, all right, or are very poor. And that creates a hole in the middle where most Americans fall into. So it's called a donut hole in lobbying. So ACA is going to attempt to get money for drugs to more senior citizens and make it more equitable. Chemotherapy for cancer. Let's try $9,000 a month. Is that hard for you to believe? That's what it costs. If you're getting state-of-the-art care, I just talked to someone last weekend, a lady, 67. She has very severe cancer, stage 4, which is about the worst. She's working, she's a nurse, and the treatment she receives keeps her, for the most part, comfortable and productive. Is that the usual cost? Is that the usual standard of care? Or should we take away her drugs? Now, it's interesting because talking to her, she feels guilty. She said to me, how many kids could be immunized on what I am costing the government a month? She's right. So you have to think that out. But is that a reason to withdraw the subsidy from someone who has lived a fruitful life, contributed to society? When do we pull back the resources? Very difficult question. All right, graduate medical education monies. ACA provides a lot for physician education because they seem to think that more physicians are going to create all the difference. Family nurse practitioners for medically underserved areas like Alaska and some places have a little sense of humor. They always put us into medically underserved areas. Damn, if they were serviced by physicians, the health wouldn't be as good. Nurse practitioners do tremendous things, and since we mentioned Alaska, in Alaska, they fly on a little helicopter into the most remote locations. They've never seen a doctor out there, but the nurses have been doing it for generations. All right, 34 million more will be insured through the expansion of Medicaid, and it's still questionable who are these 32 million. Will we get to considering illegal aliens? Right now, it's legal residents and citizens who are poor or near poor, who everyone will be required to have insurance. Some will buy it themselves through the exchange system. Others we will subsidize because they're too poor to buy it through the co-ops and the exchange system. One other point, I forgot to make it when we were galloping through here. We talked about, the age for Medicare eligibility will increase, and there'll be a means test. Right now, there are some restrictions on Medicare, and many providers won't accept it. You know that. If you accept it, the government gives you increases in your rates. Cost of living, it's indexed, a little increase in the rate you can charge. But you don't have to accept it. And whoever your provider is will give you a receipt for what you paid, and you send that receipt. You send that receipt into Medicare. They'll send you the amount of money they would have paid. You cash your check and you pay the provider. But in some cases, there's quite a big gap. There's a lot left over that you have to pay. This is why medical tourism has been flourishing. Do you know what medical tourism is? No one? No. What is it? People go to other countries for the surgery, the transplant, the care. It's usually surgery. It's not medical management, surgery, transplants. They could get here. because they're paying so much in addition to what their provider charges them. And they found out the cost in these other countries is minuscule. Minuscule. Now, another interesting piece. These other countries have established healthcare facilities based on the American standard. The newest hospitals in Dubai and Bahrain, I have never been to those countries, but I know people that have been. The hospitals have hired successful directors of nursing, we'll call them that, from the U.S., to set up their hospitals, and they're mostly staffed by U.S. prepared nurses, so that they can guarantee the same standard of care. And the magnet program, the program that accredits magnet hospitals, has begun to accredit some offshore hospitals. So you go to a hospital in Bahrain, let's say, where you get absolutely exquisite care, American physicians. You're given the same care as you would get here, and you pay out of pocket maybe a little more than, because I don't know if the government will give you anything, but you pay a little more than you would have paid out of pocket here. This is becoming India. Big. They're right now constructing hospitals according to the American standard. Bahrain, Dubai, I know there, Jordan has, this is big money, people. And the care is just as good. In fact, in Bahrain, they've put up a hotel next to the hospital, so that, because they're anxious to have you get out as quick as here, same standard, but you can go next door to the resort hotel and recuperate if you want with your family. Ingenious. And that has become very big business. Switzerland, Mexico, where some of the FDA, the Federal Drug Administration laws, don't apply for certain treatments, which leaves me with a queasy feeling that, but anything else can be done at a much lower cost. All right, so that's medical tourism has become quite the usual. All right, let's just take 5 more minutes and to start you off on this. Read carefully this for next week. The oldest professions are medicine, law, and theology. You probably knew that. And there was a report done, funded by the Rockefeller Foundation in 1915, which studied American medical schools. It's famous, the Flexner Report. Abraham Flexner is gone a long time ago, I guess, but his report lives on. And in his report, he studied American medical schools. At that point, there were thousands of them. Every hospital had a medical school in addition to a nursing school. Free labor, doctors and nurses. And the education was suspect. So he studied them, and he came out with up with 4 characteristics for a profession. Profession should be autonomous, intellectual, socially necessary and unique, and altruistic. This is what he said. And of course, his criticism of American medical schools was in addition to this. And within about 10 years, thousands of medical schools closed. And we began to construct the current system we have, which is a few hundred medical schools. A profession has certain characteristics. A profession is intellectual. And The body of knowledge of a profession is constantly expanding through research and thought. All right? And because of that, the members of the profession have a lifelong responsibility to stay in front of the learning curve, to stay on their toes. Very little of what I learned in nursing school 40 years ago, whatever it was, is even taught today. Everything that's in my head has come from continuing education from colleagues over the years. Yes, there is some basic stuff, but I can do up a patient better than anyone else. I'll tell you that. That was drilled in our heads. My corners are perfect. My sheets are tight. Nobody's going to get a bed sore from one of my beds. And certain things we learn that are still useful, but not much. The boundaries are constantly expanding, and if you don't keep on top of that, you're doing the patient harm. And our commitment, our ethical obligation is to do no harm. And I could give you examples of that, but I don't want to take the time right now. A profession, and these are all the things that Flexner came up with and used to criticize the medical professions. But they listened. Do you hear me? That always, never ceases to amaze me. They listened, and they closed them. We said the same thing in a study about 20 years later. There's a section in your book on studies that were important to the nursing profession. We said the same thing. Nobody closed. We just continued, but they closed. All right. Flexner said that a true profession entrusts its education to higher education. We don't educate in the apprenticeship mode. At the turn of the century, and shortly until Flexner, physicians were educated working with another physician, going along on house calls with Dr. Jones or Dr. Smith. That's how they learned. And lawyers learned by working with another lawyer in an apprenticeship, both of them are apprentices. And there are still a few lawyers in the United States that are barred, receive their bar admission based on this apprenticeship. They never had any formal legal education. You worked with another lawyer. Free labor, and I'm sure some learned well, but you can't guarantee that. A profession applies its body of knowledge in practical services. Medicine, law, nursing are very practical, and those services change with the times. And a profession functions autonomously. In other words, in the formulation of policy and in monitoring its practitioners, the profession is responsible. The profession is responsible to identify those people who don't practice adequately and to discipline them. And a profession is guided by a code of ethics. All right. A profession is distinguished by the presence of a specific culture and values that all its members share, and there's a clear standard of the educational preparation to enter into practice. There have been many arguments in nursing about the baccalaureate being the entry credential, and we still have the associate degree to deal with, and this is why Rutgers has such a robust RN to BSN program. We're gradually moving towards establishing that standard with the help of magnet hospitals. A profession attracts people who are looking for more than personal gain. They see the work of the profession as their life's work, and in exchange, the public grants them freedom of action, an opportunity for growth, and economic security. Not wealth, but economic security. Let me just finish by giving you an example of that. I was in Russia before Glasnost many years ago, and I visited medical school and nursing school. The physicians who were in school were glad for what they told me. They were glad for the privilege of being given the opportunity to study what they loved, what they wanted to do. At that point in time, plumbers, because they had hideous plumbing, plumbers were paid more than physicians. You're paid according to the need at that time in Russia. You were paid according to the need of society. And they needed construction people, plumbers, carpenters. They were all paid more than physicians. And when I visited the student physicians, they didn't gripe about that. You should be paid according to the need of the society. And they felt privileged that they were singled out and given the opportunity to study medicine. So we're not saying they should be paid like healthcare providers should be paid like plumbers, but we're saying that it shouldn't be a place where you go to try to get rich. Okay, a struggle home. All right? Any questions at all? Any? All right, we'll start next week. Hopefully we're talking about your papers and questions that you have when we're not in such a rush to get out. Did you look on your thing? 11 o'clock, they were going to post.
Yeah, they said classes from 1 and on are canceled today.
From 1?
Yeah, and on are canceled.
Okay, thanks.
Oh,